students, this is Dr. Tatum, and I'm hoping to finish chapter 22 in this recording, so bear with me. I believe I was cut off when I was talking about an amniotomy, so I'm on slide 25, and we're going to finish up this chapter. I'm going to skip around a little bit, but if the things that I don't talk about, I want you to read in your book. So an amniotomy is an artificial rupture of membranes. So basically, if that cervix is favorable, let's say mom is at least 2 centimeters dilated and 50% effaced, then an amniotomy might be done. And what they do is they use kind of a small hook, it looks like a crochet hook, and they place this through the cervix into the uterus and they break the bag of water. Mom is usually monitored throughout the procedure, and we also hook her up to an external fetal monitoring device. So we're looking at fetal heart tones before and also after the procedure itself. So before the procedure, we want to make sure that baby is tolerating his or her intrauterine environment fine. Hopefully we have good accelerations on the monitoring strip. And so if baby looks good on the strip and has a good fetal heart rate, then they'll go ahead with this procedure. After this is done, we have to make note of the color of the fluid. So the color, the amount, the time that the doctor did this, it's all documented. And then also we monitor fetal heart tones for a good 20 minutes. And so she is basically hooked up to this external monitoring device, and we're measuring baseline fetal heart tones, and we're also looking for any decelerations in fetal heart rate. So any decelerations, like a variable deceleration, we're watching. We're also looking for a late or prolonged deceleration that could indicate fetal distress. Sometimes when the bag of water breaks, that forceful gush of fluid can cause the umbilical cord to rush past the presenting part. And if that happens, then the presenting part of the fetus can put pressure on the cord itself. And if that's the case, that indicates cord compression. And that's when we would see those variable decelerations like we talked about in class. So those deep V's or those deep U's on the monitoring strip, that's what we're watching for. So that's what an amniotomy is. After mom's bag of water breaks, it's really important that we watch her temperature closely, just because now basically bacteria can invade that uterus. And so it's so important to monitor her temperature every 2 hours or so. If she starts to run a fever, we need to make note of that and call the provider right away, and also keep baby on the monitor so we know how baby is tolerating the situation. So let's move on and let's talk about oxytocin, I believe, is the next slide. So oxytocin is a medication that we've talked about before. This is used to augment labor. So what it does is it helps increase uterine contractions. We want those uterine contractions to become more frequent, and we want them to be at least 2 to 3 minutes apart and last 80 to 90 seconds when mom is given oxytocin. It does cause a lot of pain in labor, and so being induced with oxytocin is probably not the most pleasant experience, but it does get labor going. So there is some good information about oxytocin in your textbook on page 702. The overall goal of oxytocin administration is to increase cervical dilation by at least 1 centimeter per hour when mom is in the active phase of labor. And so we do this by titrating oxytocin to really what she needs and to how labor is progressing. So at the beginning, we start with a very small dose of oxytocin, and then about every half hour to an hour, we increase this dose. And so we like it, again, we like this dose, whatever dose we achieve, to get her contractions to be 2 to 3 minutes apart. So her dose can range anywhere from 1 milliunit per minute to about 20 milliunits per minute. Now, if we get to 20 milliunits per minute via an infusion pump, then a lot of times the doctors like to be called. If we give too much oxytocin, it can cause hyperstimulation of the uterus, and that can lead to hypoxia in the fetus. And so we have to be very careful about how we give and administer oxytocin to our patient. But again, what I really want you to learn is that we augment labor through the use of oxytocin, and we want her contraction pattern to be 2 to 3 minutes in length and last 80 to 90 seconds. Um, and then again, anytime she is given oxytocin during labor, she needs to be hooked up to an external or an internal fetal monitoring device. And that way we can monitor baby very closely, see how baby is tolerating labor, and also really have an accurate account of what her contraction pattern is doing. All right, so with that, I'm going to skip ahead a few slides actually. I'm going to skip past the vacuum assisted and forceps delivery um, slides just because we've talked about those in the past. I do want you to understand why we use a vacuum or forceps to get the baby out. And I also want you to think about the complications that can occur when we use a vacuum or a forceps in the delivery process. So here you can see the different types of forceps. I'm not going to ask you that on the test, but you can see what forceps actually look like. Kind of scary. All right, I'm going to move on to, I'm going to move on to slide 33 here where it talks about cesarean births. So think back to why a patient would have a C-section. Perhaps dystocia, like we talked about. Maybe baby was in a breech presentation and mom's bag of water broke. Maybe mom just had lots of different complications related to her pregnancy, and the best method to get baby out was via a C-section. But I want you to know that C-sections are major surgery. And so with that, there's lots of different complications that can occur for moms that do have a C-section. So surgical techniques, the most common type of technique that they use is a low transverse incision. So it's kind of a bikini cut or bikini incision. So it's very low in the suprapubic area. It works well for moms that have to have additional C-sections with further pregnancies. And then the vertical incision is sometimes used, which is right here. And this vertical incision, you can see it's more lengthy. And if an incision like this is used, it does cause a lot of stress on the uterine wall, especially with subsequent pregnancies. And so there's always that chance that she could have a uterine rupture if that is the case, if she has more problems with pregnancies as she advances in childbearing process. What I do want to point out are the complications and risks associated with a C-section. So complications, if you can think about it, complications for mom and for baby. So maternal complications could be aspiration related to the procedure itself because of the anesthetics involved. It could be hemorrhaging because it's surgery. We're cutting into her abdominal cavity. We worry about atelectasis and pulmonary edema, especially since she has had a major surgery. A lot of times, if she's now exercising those lungs and getting them expanded like we want them, like we want her to, there's that good chance that she could run a fever and maybe have atelectasis. We worry about infection of the endometrium, so endometriitis. So endometriitis basically surrounds the whole entire uterine cavity, and that can cause a massive infection. Wound dehiscence or separation of those of the wound edges. We worry about urinary tract infections because most likely she's going to have a fully placed during the procedure. And then there's always that chance that there could be an injury to the bowels or the bladder. We can nick something during surgery. And then mom could also have problems with anesthetics. For fetal complications, we always worry about fetal asphyxia. We worry about fetal injuries like a scalp laceration related to the C-section. So all of those are risks that she needs to know about. And then we also need to educate her on some of the prevention of those maternal risks as well before the procedure. All right, I'm going to keep moving on, and we're going to talk about post-term deliveries. So let me move to let's see. Yeah, we'll move to slide 36. Um, just a few things to point out with a post-term pregnancy. I want you to think of macrosomia. Macrosomia is basically an enlarged baby. So moms that have gestational hypertension, she is going to be at risk for macrosomia. But even so, a healthy pregnancy, if baby gets to 41, 42 weeks, baby can be quite large. And so baby can also be over 8.5 pounds. And so we worry about just an enlarged baby. And then with that, we worry about extra bleeding related to just the size of the baby with a vaginal delivery. We worry about the placenta starting to deteriorate or calcify. And sometimes this does happen, especially when the baby gets to 41 or 42 weeks gestation. And so just gas exchange is not the greatest. And you might be able to see that on a monitoring strip. You might see some late decelerations. And then we also worry about meconium stained amniotic fluid and the risk for aspiration related to that. So those are just a few things to point out to you here. When a baby does get to about 41 or 42 weeks, the doctor's probably going to do an induction. We want to get baby out just because it's less safe for babe. We're going to watch the baby closely through a non-stress test where we're watching baseline fetal heart rate, and we're also watching contraction patterns. And then a lot of times we'll do more of an in-depth ultrasound called a biophysical profile. And we can watch mom's amniotic fluid levels. We can look at breathing movements of the baby. We can look at muscle tone of the baby. So it's a good, accurate description of really what is occurring at that point in time. All right, I'm going to move on and we're going to talk about shoulder dystocia very fast. Shoulder dystocia can be very scary, but this is when the head is born, but the anterior shoulder gets stuck and cannot pass under that pubic arch. And so when this happens, most likely the doctor is going to have to break the baby's clavicle in order to get baby out. But we do put mom in a position called the McRoberts position, and you can see this here. So she brings her knees all the way up to her chest and kind of puts her legs out into a frog-like position so that will open up her pelvis. And then the nurse is going to put downward pressure on the symphysis pubis area. And that constant pressure that the nurse is applying to that symphysis pubis is going to help pop that anterior shoulder out so baby can be delivered. The biggest complication is a lot of bleeding for mom, any lacerations. And then we also worry about hypoxia in the baby because this is very, very stressful. So it is something that you might see in practice. Another injury to baby might be the brachial plexus injuries, especially if they're using a lot of pulling efforts on baby's neck area. Sometimes that neck area can become quite injured because it just gets stretched because the doctor is trying to pull the baby out. So it is kind of an ugly situation and it can be scary for a lot of women. So that is shoulder dystocia. And then the other one is a prolapsed umbilical cord, which we kind of talked about. But this is when the cord lies below that presenting part. And here, if a baby has a very long umbilical cord, greater than 100 centimeters, usually an average cord is about 55 centimeters. So you can see the length can be a factor. If baby is in a frank breech presentation where the legs are all the way up over the head, that can also be a risk factor. And then the unengaged presenting part, meaning that baby is not at zero station. Baby's head is not engaged into that pelvis yet. What happens is the nurse has to intervene very quickly and lift the presenting part off the cord. And so usually she'll put a sterile glove in on her hand, do a sterile vaginal exam, and lift that head or whatever presenting part is off that cord. And she will not move her hand until that baby gets delivered, whether it be vaginal or C-section. If mom's cervix is well dilated, fully dilated, then they might deliver vaginally. If not, then she will have a C-section. But the biggest thing is if there's cord sticking out, make sure you keep that cord moist. Put a sterile gauze dressing around that cord soaked in saline. give mom oxygen, and then we try different position techniques, which you'll see